You're listening to the Cancer Assist podcast. Wherever you are in your experience, we are here to provide help and hope as you navigate cancer prevention, treatment, and care. Hosted by Dr. Bill Evans and brought to you by the Cancer Assistance Program. Help when you really need it.
Welcome to the Cancer Assist Show with Dr. Bill Evans, and today I'm going to interview Dr. Dath, who's a professor of surgery at McMaster University and a hepatobiliary surgeon at Hamilton Health Sciences, and I think at St. Joe's Healthcare as well.
Yes.
Well, welcome to the program, and I think it'll be very interesting to our listeners to first of all understand what is a hepatobiliary surgeon.
Thanks, Bill. So hepatobiliary surgery refers to surgery of the liver, the pancreas, and the bile ducts that connect them, and any of the diseases that have to affect those.
And some of that's cancer, and that's what we're going to focus on, but that's kind of what when I was kind of doing a bit of surgery way back again in my past as an intern resident, we call it tiger country, the pancreas, the biliary tree. There's a lot of important structures in that area. So it's a specialized area of surgery. It's not what general surgeons typically do. So maybe tell us a little bit about the training involved to get to the point where you wear that name of hepatobiliary surgeon.
Sure. So all the surgeons who do hepatobiliary surgery start off as general surgeons, and then go on to what's called a fellowship, where you do a focused area of training on looking after surgeries with respect to the bile ducts, the liver, and the pancreas. A good bit of that is cancer, as you mentioned, because that's kind of what we typically end up having to deal with that. But other things, like sometimes simple things like stones in the bile duct, etc. Very difficult issues with gallbladders and things of this sort can sometimes be a problem too. But we focus on that so that we can pay attention to the specific diseases that happen there and the special skills that we develop so that we can do that well.
So it's a specialized area, and you've had advanced training, and there aren't that many of you.
No.
I think there's only, 3 or 4 in the city?
There are 5.
5 now.
And I've just shared my practice with a new surgeon called Dr. Yasmin Isaji, who's joining my practice. And so now there are 6 of us at the Juravinski Cancer Center.
Well, that's quite a formidable team you now have, and that's good to hear. And it's not just surgeons, but you have a team of medical and radiation oncologists and others who get together to discuss cases, I think, as well.
Absolutely. So there are several key other players as well. So the medical oncologists help us because we very commonly will use a combination of medical oncology as well as what we call surgical oncology. Sometimes radiation oncologists help us with that too, because there's certain particular cancers or cases where that's useful. But just the specialized nursing on the wards, the specialized nursing in the operating room, the equipment we have there and so on is very important as well. And lastly, there are 2 other specialties we don't see very much. One is radiologists. They're very important in us being able to identify things, interpret things really well, decide what are the next steps to investigate things really well, and also the pathologists who look at these, because sometimes the decision about whether something is or isn't a cancer can be very nuanced, and we have specialized pathologists who help us with that as well.
And I think you get together for conferences on a regular basis to talk through the management of these patients?
Absolutely. So I tell my patients when they come to see me, they come to see 6 surgeons because they all will be able to...
That might be very frightening to hear.
Well, the good thing is you get 6 heads instead of 1.
Exactly.
And that discussion and the what about this and what about if you tried this here instead, those kinds of things are what we try to do to advantage the patient in terms of these difficult situations that sometimes come up.
Right. So why don't we talk about each of the major organs that you would operate on that might have cancer, and maybe start with the liver. Maybe the average person doesn't know what the liver does, so
Sure.
Perhaps a good place to start is explaining liver function, and then we can talk about the cancers that affect it.
So the liver is this big organ that sits just under your diaphragm, just under your chest. It's a top organ in the belly, more across to the right side, and the gallbladder hangs just underneath it. And the liver is what people generally term as a factory of the body. So it makes a lot of the chemicals that your body uses to run. It detoxifies things. So when you eat something, if something were not that great, the liver helps detoxify it before it gets into your blood. Those are some of the big things that it does. It synthesizes or makes things, and it detoxifies or cleans things. It's also very unique in that its position allows it to its position is crucial to how it does its work. It has to stay between where the bowels are and then where the blood gets back to the heart, and so blood flows through there before it gets anywhere else. And that particular position can sometimes be a problem too when you hear about things like cirrhosis. Cirrhosis makes the liver hard. The blood has a hard time going through, and so some patients who have cirrhosis of the liver, and I bring that up because that's something that affects people with cancer too. But if you have cirrhosis from the liver, it sometimes can make things very difficult for us to work on the liver. But its position gives it that risk of having that problem.
So, like every organ in our body, it can develop cancer. And so there are liver cancers, or we call them hepatomas or hepatocellular cancers. But there's a spectrum of them, and there are things that are on the benign end and things that are on the malignant. Mm-hmm. Maybe explain a little bit of that, and what actually are some of the risk factors for developing the cancers you might operate on.
Sure. So within the liver, there is the substance of the liver itself, plus the bile ducts, which are the tubes that take the bile into the bowel. You can think of those as two, almost like two separate organs in one organ. So let's put the bile ducts by themselves separately. That's called cholangiocarcinoma. Let's put that separately for now, and look at the stuff of the liver. And in the stuff of the liver, the kind of cancer that can come there would be called a hepatocellular cancer. So a hepatocellular cancer is one that arises from that liver cell itself, and it's one of the most common cancers in the world, actually. We don't see it as much in North America, but there are certain areas around the world where it's what we call endemic. It's there because there are lots of risk factors for people in those areas to have that kind of cancer. And it's one where we don't have tons of great things to do yet, but there's been lots of advances recently. So we find that kind of cancer is something that grows in a liver where the cirrhosis happens. And the cirrhosis can happen from lots of things. Hepatitis, for one, is the big thing, but there are other kinds of infections as well. And so in terms of hepatitis, we have hepatitis B and C, those kinds of things. We now have medications for some of those things. So we are treating people and minimizing some of those things much better than we used to. And then there's alcohol, which also causes some damage to the liver and can cause cirrhosis. And that's more common here because we have less of the viruses that cause it. But in general, if the liver starts to get damaged with cirrhosis, that ongoing smoldering damage that happens with the virus or with the cirrhosis can lead certain places in the liver to become cancerous. And the problem with that is it can become cancerous in more than one place. When we do an operation or try to look after patients with that, we first try to make sure that their function is okay. The cirrhosis affects the function of the liver. And so we talked about people we work with. So some of our gastroenterologists or hepatologists who are gastroenterologists that specialize with the liver, they help us to maintain the patient's function, to try to optimize things so that the liver is working as well as possible. And then in that situation, we look at what the cancer is doing, where it is, what we can do to take it out. The gold standard, or the best thing we know right now, still is surgery, but there are lots of other things that are coming up. Some of those things are what we call ablative therapies, where we ablate or destroy the tumor. We can do that in several ways. The most common ways to do that in Hamilton are to put something called a radiofrequency probe. So it's a needle. It's a very specialized kind of radiosurgery, to put it that way, where the radiologists actually do the work. And they put the needle in using fancy techniques of ultrasound and CT scans to put the needle exactly where they need to. Mm-hmm. And then they can ablate or destroy the tumor by putting the tip of the needle within the tumor and destroying it that way with heat, using a radiofrequency current. They can do something similar with a microwave. Mm-hmm. And those two techniques exist within Hamilton right now. There are some other things coming down the road as well. So they can ablate things that way. They can do something called an embolization, where they can target the exact artery going to that particular type of the cancer, the place in the liver where the cancer is. And they can shoot some chemotherapy into the liver in that area, and they can give a very high dose of chemotherapy to that one spot. And then the liver will kind of degrade the chemotherapy before it goes to the rest of the body. So it's not like you have lots of other side effects of the chemotherapy. So you can use a high dose in a very, very specific area to try to get rid of those kinds of cancers as well. And we have that here too. We can do that. It's called TACE, or transarterial chemoembolization. Sometimes, if the chemotherapy part might be toxic, we can even just put what we call small beads or tiny bits of, you can think of it like dust. Put dust in the artery and plug up those arteries so that the artery leading to that tumor itself will not give the tumor enough blood supply and the tumor can die away. Some of these aren't curative, but they're helpful. And patients have done pretty well with those. And we've had some good results with that here in Hamilton as well. And then the last thing is, is chemotherapy. So sometimes we have no choice but to say the only way to look after this is to give the patient a kind of chemotherapy like more conventional chemotherapy in the veins and allow that to try to look after the tumor itself. So those are lots of ways to look after hepatocellular cancer.
So the decision making is complicated, I would
That's
think.
exactly.
Figuring out which patients can tolerate the surgery
Mm-hmm.
versus those that would be better candidates for ablation. And, liver surgery wasn't common when I was practicing, but better knowledge and better of the lobes and lobules and the techniques of liver surgery have made that much more viable as an option. Even
Absolutely.
substantial amounts of the liver, surprising how much of the liver can be removed, and then it will regenerate itself, correct?
Correct. So we've gone from not being able to operate on the liver when I was in training to being able to do, some pretty major operations, to now being able to do those operations laparoscopically. So one of my colleagues and I in Hamilton began doing laparoscopic liver surgery back in 2005.
And just for our listeners, maybe just explain what laparoscopic surgery is.
So laparoscopic surgery is where we use some tiny incisions, what we call keyhole surgery. So instead of making this large operation that's under the rib cage and across the midline to under the other side of the rib cage, we now make something that's a small incision, big enough to just about the size of my wrist actually. And with that, we can use some tiny instruments the size of pencils, long skinny pencils. And those are the instruments we use to manipulate the liver and to then resect or remove that tumor from the rest of the liver. We take that piece of the liver out through what's called a hand port, or that one incision you make to put one hand in. So instead of making an incision big enough for everyone to put their heads in and see, we make a tiny incision just big enough for one hand to go in and use other tiny ports to be able to see and manipulate well enough to be able to manage the operation. So my patient right now in the hospital right now, he's post-op day 3 and he's about to go home. And he's going to have a small incision in one corner, and he's up and walking around and doing pretty well.
So there's a lot less trauma to the patient in that kind of surgery, so that
Right.
shortens their recovery time and speeds their departure from hospital, all of which is good for them and for the health system at the same time.
Right.
Yeah.
You can imagine that if the operation included this 20-inch long incision, the liver, which we've just decimated, we've just taken a bit of it out, would have to look after regenerating itself, plus look after this huge incision and all the trauma from the incision, but now the incision is much smaller.
In terms of the liver regenerating itself, is there anything you have to do in terms of support with, parenteral nutrition or things of that nature, or just regular feedings and does it recover on its own? It seems like such a big thing to remove, say, half a liver and have it regenerate.
Yeah. I like to think of the liver as a magical organ because we don't really do much. We take a piece out, and because of the way the liver functions and the way it's set up in the body, like I said, between the bowel and the liver, it receives its own kind of what we call growth factors from the bowel. So as we take a piece away, there's more growth factors for the rest of it. And so the rest of it says, I've got all the growth factor in myself now, so I'll just grow all I want. And it will grow up to almost the size of what it was before we took the things out. Usually about 75% of the size it was.
Yeah, that's remarkable.
Yeah.
So, and what are the results like with liver surgery, like when you do resections for hepatocellular, assuming that you've selected them carefully and they're not big tumors and multiple lobes and so on? What are the results like?
So it's variable, I guess, but what we've tried to do is to pick and choose so that what we use for surgery versus radiofrequency ablation or embolization, etc., has to match with what the patients need. So in those patients where we choose surgery as the best option for them, they're usually somebody where we expect that the operation is curative, right? So we're trying to see if we can cure the operation, and surgery is the best way to try to cure that. The good thing about hepatocellular cancer is that it grows in one area, and if you take that entire piece out, right, as long as it's a single lesion or a single spot, if you take that whole thing out, you're probably not going to get that recurrent, right? Now, we said that hepatocellular cancer is one that can regenerate in different, you can have different ones. So it's not that the cancer may come back, but you may actually have a new cancer form because the other parts of the liver are still cirrhotic. There's still that cirrhosis there, causing that ongoing smoldering process that generates cancer. So that can happen too. So patients do tend to end up getting another cancer someplace else sometimes, but with surgery we tend to be able to take that out and then watch people to see that things are okay. And it's not a one-shot deal. So if we did that surgery on someone and then several years later found that there was another cancer, we can still sometimes go back and do another surgery. But more than likely, we would end up being able to do at least something like an ablation. And the other thing is that because we watch patients closely when they've had surgery, we continue following them afterwards, we pick up those other tumors if they're coming up when they're a small
quite
size.
early,
Yeah, and when we can do something about it.
Right. And are there any blood tests or particular imaging tests you use to follow the patient to pick up those lesions early?
There are two things. First of all, like I said, our gastroenterologists also work with us, and they're the ones who follow patients who have hepatocellular cancer, who have a risk of hepatocellular cancer. So somebody has cirrhosis, sees the family doctor, that cirrhosis is diagnosed, and a hepatologist or a gastroenterologist might follow the patient, make sure that they don't have funny blood vessels growing, make sure that they don't have worsening of the liver function, and generally watching to make sure that they don't end up having a tumor growing in the liver. If they do find that, then they send the patients to us, but they can confirm that with a blood test, right? So it's called alpha-fetoprotein, which is a blood test as a marker for hepatocellular cancer, which is also called HCC, by the way, hepatocellular cancer. So we can do that to make sure that we find those things and watch them and use that marker as a guide. When we do the operation, we can then follow up with the alpha-fetoprotein again on a regular basis, along with CAT scans. So with the patients who have done these operations on right now, every 6 months I will follow up with a hepatocellular, with a hepatic CT scan or CAT scan, as well as the alpha-fetoprotein. And along with me, the hepatologist also follows them to make sure the liver is doing well. So they end up having two doctors continue to follow them after their operation.
Great. Now, I guess maybe we should clarify to anybody listening that we're talking about tumors that arise from the hepatic cells, but far more commonly it's metastasis from cancers in other parts of the body that go to the liver. And sometimes there's a role for surgery for those metastatic deposits as well, right?
Yes. So metastasis is a tumor that's left its original place and gone someplace else. And the common thing that we see, first of all, like you said, there's lots of things that can go to the liver. The liver ends up being, because of its function and its place, it ends up being able to trap sometimes these metastases or these unusual growths in different areas. So it can come from the lungs or from the adrenal gland or from the breast or the prostate or anywhere. It could end up in there. And there's certain kinds that more often end up there than not. But the types we commonly see in North America that end up there are the ones from the bowel. And bowel cancer, so colon cancer is one of the, I think it's the fourth most common thing right now. So we see more colon cancers than we see liver cancers. And those colon cancers, if they do metastasize or spread, they tend to spread within the abdomen, and then within the abdomen they tend to spread to the liver. So when I first began my training, again, just to see how things have gone over the course of time, about 30 years ago, if we saw someone who had a metastasis or a spread from the bowel to the liver, we would try our best, but we knew that our results were very, very poor to try to help those patients. We would expect that the chance of them having any long-term survival was very poor or none. But now with surgery, we can actually take out those tumors as well. Now, those tumors can end up anywhere, and sometimes there are more than one. Again, so again, the operation that we that we did just recently for one of the patients means I took out some of the liver on the left side, another piece in the back, and another piece on the right side. So, and as you said earlier, we know about how the anatomy of the liver works and how we can go in and specifically take out what we call an anatomic section. And by doing so, we save the rest of the liver properly so that the piece we leave behind can function well. So he's having good function right now because we left him with lots of the volume of the liver to manage. But we've taken out the metastases or the tumors in these 3 specific areas that our radiologists have helped us to find. And that's kind of that collaborative process we talked about. The chemotherapy doctors or the medical oncologists have already prepared him by giving him chemotherapy for the operation. Our radiologist and I would have gone through and planned what we could do for the operation. We carry the operation through. Our nurses and our special helpers all through the hospital help to make sure he's well. And hopefully he goes home tomorrow, with his family and doing okay.
I guess, again, thinking back in time, as you said, you wouldn't have operated on it at a certain point. Then there was a small number of metastases. The surgeon said that they would take maybe up to 3. It seems to me they've gone even further now in terms of the number of metastases, if they can remove them and they're in anatomical areas and leave a sufficient amount of liver. So it's really quite a radical change in the aggressiveness. But colon cancer can be in itself, even though metastatic, fairly indolent, so that it's worth resecting those lesions to get good quality of life for the patient.
So we know that if you have one tumor, and let's say someone has a colon cancer, they have the tumor removed in the colon, they're doing okay. 2 or 3 years later, when they're getting followed up, they find that there's a spot in the liver. It probably was there to begin with. Microscopically, we didn't see it. It's just come up now because it's kind of reactivated, let's say. And we know that if that scenario happens, that going and taking out that one specific tumor, if we can do that, means that the patient has a pretty good chance of a good outcome. If we see somebody who has a colon cancer and at the same time they have a whole bunch of other tumors in the liver, the prognosis for that patient is not as good.
No.
The chance of us being able to cure the patient is not as good as it would be. But there's no reason why we can't try and give that patient that opportunity if it's technically possible. And the technical possibility has a lot to do with, first of all, whether chemotherapy does help with them. So in patients who are chemosensitive, they tend to do better. And in patients who have tumors within the liver, where we can design an operation, like I said for my patient recently, whether it's in one place where we take one piece out with all the cancers in it, or even if it's in several places where we specifically go and choose a resection or a removal in different places, right? 3 different places in the liver at the same time on Friday. If we can do that and get rid of all the visible cancer in that patient who's chemosensitive, they also stand to have a good outcome.
So it's quite an evolution in approach to metastatic disease to the liver. It's impressive, and it's producing better results for patients, and it's great to hear. I think we'll take a brief break now and come back and then talk about the 2 other types of cancer that a hepatobiliary surgeon works with, the cholangiocarcinoma or bile duct cancers and pancreatic cancer. So we'll be right back.
We'd like to take a moment to thank our generous supporters, the Hutton Family Fund and Banco Creative Studio, who helped make the Cancer Assist podcast possible. The Cancer Assistance Program is as busy as ever, providing essential support to patients and their families. We remain committed to providing free services for patients in our community, including transportation and equipment loans, personal care and comfort items, parking, and practical education. These services are made possible by the generosity of our donors through one-time gifts, monthly donations, third-party fundraising, corporate sponsorships, and volunteer opportunities. Visit cancerassist.ca to see how you can make a difference in the lives of cancer patients and their families.
We're back with Dr. Dath talking about hepatobiliary surgery for cancer, and we talked about hepatoma or hepatocellular cancer in the first section. Now we're going to talk about 2 other types of cancer that the hepatobiliary surgeon operates on. First, ones that arise from the bile ducts or the gallbladder, called cholangiocarcinomas. And then we'll touch on pancreatic cancer. But I guess the cholangiocarcinomas are much rarer Well, it's a pretty rare cancer to begin with, and then there are different types of them, but either within the liver, in the bile ducts that are within the liver, and those that are in the sort of the hilum where they come out of the liver, and then the extrahepatic biliary tree. And I guess the surgical approaches are dependent on location, and I guess the survival and benefits to the patient vary as well on the anatomical location.
Yeah.
Tell us about that kind of surgery and how it's maybe evolved over time.
Sure. So cholangiocarcinoma is one of the spectrum of diseases that happen within that hepatobiliary area we talked about. And there are lots of similarities sometimes between those and the pancreatic cancers, the gallbladder cancers, and so on. And along with cholangio, we tend to put together gallbladder cancers. So gallbladder cancers are not that common, but they can happen as well. And they come from the biliary tree because the gallbladder basically is like a bud off the biliary tree. It's kind of a specialized place where we just store the bile. You can think of cholangiocarcinoma as 3 different types. One is it happens within the liver itself, within those tiny tubes within the liver. And the bile ducts, I'm not sure if you mentioned this earlier, but the bile ducts are basically the collecting system within the liver that collects all the bile the liver makes and transfers it into ever bigger ducts. Kind of like the small branches in a tree will get whatever the nutrients the leaves make and take it down to the roots, etc. The bile ducts take the bile and bring them into bigger and bigger bile ducts until it gets to the one central bile duct that goes from the liver down to the bowel. Now, the bile duct takes a shortcut through the pancreas as it gets to the bowel. It has to, that last 1/3 of the bile duct goes through the pancreas itself, so we'll get to that in a second. But if we start off at the top, in the tiny tubes, the tiny ducts of the bile ducts, those are called the intrahepatic or the within the liver cancers of the bile ducts, the intrahepatic cholangiocarcinoma. And sometimes those end up, can grow very big because the liver it's a magical organ. Things can happen within the liver, and it's a large organ, and nothing's really going on in terms of symptoms until it gets to the edge or the outside layer where you might feel something because that's where the nerve endings are. But other than that, the liver goes about its business, and if one area is being affected by a cholangiocarcinoma, the rest of it's going about doing its factory work and doing its decontamination work, and it doesn't really bother about that one spot. So you can have some other symptoms like weight loss or maybe fevers or feeling lousy, etc. Those kinds of things. The kind of general kind of symptoms that many cancers can do. Cholangiocarcinoma can do that too, and sometimes that's how we find them. But more commonly, we end up finding them because somebody had something done to check for something else, and we find a spot there. And it can look like any other kind of cancer. It could look like a bowel cancer. We have to figure out then whether it is some other kinds of cancer or that kind of cancer, cholangiocarcinoma. Sometimes it requires a biopsy. But then once we figure out that's what it is, if it's just a cholangiocarcinoma in an area of the liver, and the rest of the liver is in good condition, and it's someplace where we can take that cholangiocarcinoma out, we'd go ahead and do that, right? If the patient's fit for that operation, the patient should have that operation because that's the best thing to get them better. And then the survival of that is not bad if we can make sure that we can get all of it. So if what we hope to do in surgery is have what's called a negative margin, which means that where we come across the liver, where we cut the liver and divide it into the cancer piece and non-cancer piece, that edge where we come through can't have cancer at the edge. Because microscopically then it could be cancer on the good side. So we want to make sure that as far as we can manage, we take out the cancer with a kind of a rim of normal tissue, because that normal tissue may have microscopic disease in it. We go around far enough to make sure that that doesn't happen.
Right.
If that does happen, that's the best outcome for the patient. And then we watch again, like other cancers, we watch again to see how things are going and see if anything's coming back and deal with it if it does. Then there's the central ones, which are really hard. And they're hard because we said the liver is a big organ, and we said it's complicated, it has lots of things to do. So the bile duct comes out of the liver to go to the bowel. But along the bile duct, right next to it, are several other structures. So the artery that leads in and the vein that leads into the liver are right next to the bile duct. So if a cholangiocarcinoma starts to form, it takes very little before it gets outside the bile duct and starts affecting the blood supply. And most of the time, if the blood supply is affected, it might mean that we can't take that piece of liver out because we can't sacrifice that blood supply to the liver. So I think of it like the cable that's going to this microphone will have several wires in it. If the cholangiocarcinoma is a tumor in one of the wires in this cable, then the other wires within the cable can also be affected within that cable very easily. There's no space there, right? So the minute it grows outside the bile duct, it's touching something else. And that makes it hard for us to do surgery sometimes for patients. For the ones where we can do surgery there, it's usually a very large thing as well, because if it comes to the area where the bile duct splits into two, and it affects one of that, well, that one bile duct is serving half the liver. So sometimes, although the tumor itself might be very tiny, it's already affected all the support structure for half the liver. So those end up being bigger surgeries sometimes. So we do try those and do those as best as we can in patients when they do have these kinds of problems. And we have some successes, but we don't have the same kinds of success in this kind of cancer as we do with hepatocellular cancer or with bowel cancers and metastases, for instance.
And the anatomy just makes it impossible because of the proximity of these important blood vessels.
Yeah. And the other trouble is the gallbladder is the same way. So the gallbladder, when the gallbladder has a tumor, gallbladder tumors tend to grow a bit faster than, say, liver cancers or sometimes even pancreas cancers. And so they can, and because the gallbladder is right tucked up under the liver and in the same area as this cable going into the liver, it doesn't have to grow very big before it can get to a point where it ties our hands. We can't do something because the vital structures to the liver are already affected. So we do that. There's one caveat to that, which is sometimes a person will go in to have a typical gallbladder operation for gallstones. They've got symptoms, we diagnose this as gallstone disease. We go in. When they take the gallbladder out, the pathologist who looks at all these specimens afterwards anyhow can sometimes find that there's a spot there that's cancer. Sometimes, according to some fancy kind of algorithms we have or ways to look at what the best options are, sometimes we will say that according to these particular factors, we should go back and do a bit more of an operation than just the gallbladder operation to try to get those negative margins we talked about, right? Or to try to get beyond the cancer surgically. So sometimes those things happen, and we try our best to look after that too, but they are very difficult to do.
You're in tiger country.
That's the tiger country for sure.
And I imagine that the number of times that operating for gallstones, you find a small cancer that's in the gallbladder is pretty rare, so that probably the collective experience of managing these things is challenging. In my reading for this podcast, I came across a reference to surgeons doing liver transplantation for some of these, and I guess in some sites, in some centers it may be done. It seems like a real heroic, maybe a Hail Mary kind of initiative to do a total liver transplant for either hepatocellular cancer or cholangiocarcinoma. What's the thinking in Hamilton and Canada?
So in Hamilton, we don't have a liver transplant team because there's one in Toronto and one in London. So we're bracketed by good people who can do that already. And reproducing that function here didn't seem to be a good idea at the time, so it hasn't happened yet. With respect to liver transplant, we typically will say the cure rate for hepatocellular cancer by taking it out is pretty good. If you do a liver transplant and take that out, that's also pretty good. But the chance of recurrence by doing a transplant is very, very, very low because you've taken out all the cirrhotic liver, right? So remember we said that in hepatocellular cancer, the liver cancers, that if you take that cancer out, you've done a pretty good job of trying to make sure that's not there anymore. And that's a pretty good, it's usually very good because it's not like the cancer spreads all over the place in tiny areas here and there. It's pretty good that if you do that operation, you're done. The other thing we know is that hepatocellular cancer doesn't commonly go to other areas of the body. It stays within the liver. And that's one of the reasons why we can do a transplant. Because if we can find that this tumor is within the liver itself, and there's good evidence that there's nothing else anywhere else, then if you do a transplant, you're taking that whole cancer out. The problem with doing that with other cancers, like bowel cancers, for instance, is that the bowel cancers, by definition, already have access to the rest of the body. So microscopically, there could be tumor here or there, or whatever. If you find that there are metastases or tumors from the bowel to the liver, and you decide that you want to take the liver out and transplant it, how do you know that there aren't other areas that would kind of have a resurgence of the cancer after the transplant?
And particularly when they're on immunosuppressive therapies, which
Yes.
may make it easier for the metastasis
Yeah.
to spread. So,
Right.
yeah, I was sort of surprised to see transplantation even listed as a possibility in some circumstances, but you've explained it well as to why it might benefit some patients with hepatocellular cancer, but highly selected patients, I imagine.
Yes.
Talking about highly selected, I guess the patients who are candidates for pancreatic surgery are also rather highly selected, because the vast majority of them seem to present with more advanced disease. It's not readily resectable, but the best treatment for pancreatic cancer is a surgical treatment where it's possible.
Correct.
And again, it depends where the cancer is in the structure of the pancreas, whether it's in the so-called head or body or tail. Tell us a little bit more about how
Sure.
the surgeon approaches that.
So again, this has a lot to do with where the pancreas is, and this is an organ that's tiny. So I tell my patients it's about 2 fingers long, 2 fingers high, and 1 finger thick, right? So if you want to kind of get an idea of what it looks like, that's the visual you can use. And then that organ, that tiny organ, is very well protected because it's very fragile. So it's sitting right in front of your backbone. The trouble is, of course, there are other things in front of your backbone, like your major vessel going into the rest of your body, a lot of the nerves that go throughout the rest of the organs. And there are 2 major vessels. One of the vessels is that big vessel we said that takes the liver's blood supply to it from the bowel. So the bowel drains all its blood into the liver first, and that large vein called the portal vein and the superior mesenteric vein, those are the veins that go up to the liver. They run directly behind the pancreas. In fact, the pancreas is kind of half around them. There's another one called the superior mesenteric artery, and it takes the blood, the fresh blood from your heart, and gets it to the bowel so your bowel can live. So those 2 vessels are the ones where we typically find that if they're involved, it makes it more difficult. Now we have lots of ways to deal with the vein one, the portal vein and the superior mesenteric vein. There are lots that we can do now that we didn't do before, but there's very limited utility or very limited usefulness, I guess, and even approaches to be able to look after the artery, because that's where things get dicey. It turns out that the artery is also covered by a set of nerves that go down to the bowels and help serve the bowel. And so if you start dividing those things or taking those things away with the artery to try to, take a piece out and put it back together, you tend to end up having some complications from that too that might make the entire operation not that good. So we try to make sure that the operation is possible by, first of all, looking at whether the tumor is within the gland itself, within the gland of the pancreas, or just around the pancreas a little bit, so it's not into these other nearby structures. That's where those multidisciplinary rounds, or those case conferences where we get the radiologists and the surgeons all looking at these, we pore over those very carefully, every single one, and look at where the tumor is. How close is it to the artery? How close to the vein? How much of the vein might be involved? What could you potentially do if you had to take a piece of the vein out and put it back together or repair it? And then, is there anything in anywhere else? So pancreatic cancer, as you said, starts off as a small tumor. It can grow in just a very small distance to get to other areas that will make us not be able to take it out, like the vein and the artery. And it can start to spread to other areas like the liver or like the other lymph nodes around the area without the patient knowing too much. The ones that grow in the tail tend to keep growing and get larger and larger, and they will start to even spread before anything bad happens. It turns out the tail of the pancreas isn't around anything that's very vital or that will cause symptoms right away. So those can grow bigger without causing any symptoms at all. And by the time we find those, either by accident or because the patient has symptoms, they might be already metastatic. They may have already sent off, other tumors to other areas like livers, etc. So sometimes we don't catch those in time. The ones that are on the head side are the ones where, in some patients, they're lucky because it grows right next to the bile duct. We said the bile duct takes a shortcut through the middle of the pancreas. So if there's a tumor, think of the tumor like a marble, right next to a small tube like a straw. As the marble gets bigger, it'll push on the straw and squish the straw. Then the liver is trying to do its work and get its bile out, but it can't because the straw is squished. So those patients get jaundice, and that's kind of how we find them sometimes, the patients get jaundice. Well, if it's still the size of a marble, we can take that out. So sometimes it's lucky, if you can use that word at all in cancer, it's lucky that it grew in that one area where you get a color-coded diagnosis.
Yeah.
Right? Someone comes in,
diagnosis, yellow.
and then we kind of know, right?
Yeah.
So just the other thing is also, most people who get jaundice, just so you know, for your listeners as well, most people who get jaundice don't have cancer. They usually have gallstones.
Right.
Thank goodness, right? But for those who do have that color-coded diagnosis, it allows us to then, get the engine going really quickly, do the appropriate assessments, get that team together to check it out, and then plan things. The things that have changed more recently, though, Bill, is that we are now seeing that there is better chemotherapy for pancreatic cancer than it ever used to be before. We're seeing some patients who have responses to chemotherapy that are phenomenal compared to when I started. And there are patients who have had tumors we thought were unresectable, unremovable. We give them chemotherapy, we know that the tumor shrinks, and when we go to take the tumor out, we find that the large areas of the tumor are what we call sterile. The tumor is completely gone, and there's just scar tissue there now. That allows us to think about the future of giving patients chemotherapy, doing an operation, and seeing that we've taken out the whole thing with negative margins. We talked about that negative margins being so important for us having a good outcome. Well, if the chemotherapy gets us to negative margins, even if it's not completely sterilized, it allows surgery in patients who would not have had surgery before, right? Because we would have left them with positive. So we tend not to take patients who we look at having positive margins to the OR. And some of them are what we call borderline now. So this is another term that your patients may hear, patients and the families, is a borderline resectable tumor. And that's one where we think, well, it might be touching the vein. We can maybe optimize that by giving chemotherapy first and then going to surgery afterwards. Our team in Hamilton is very aggressive with doing what we call a multidisciplinary approach, or a multi-pronged approach to looking at this, with chemotherapy and surgery together rather than just surgery. And I don't know that the literature or the things that are out there for patients to access are looking at this yet. But this is how we're foreseeing the future, and the improvement that we can bring to patients is this combined approach.
That's encouraging to hear, because unfortunately pancreatic cancer has this terrible reputation, doesn't it? And
it does.
We all know of individuals who were diagnosed and 3 months later they've passed, which is sort of the average life expectancy after a diagnosis. But if we increase the potential for operability by what we call neoadjuvant chemotherapy or preoperative chemotherapy, that would be a huge step in the right direction.
Yeah.
It was very interesting. This is like an anatomy lesson here today. It's too bad we're not doing visuals, because it would certainly help with people to understand the complex anatomy in the upper abdomen and where these important arteries, the superior mesenteric artery and the celiac artery and the portal vein, where all these structures run in relation to the pancreas and so on. But I think your word images have been really, really helpful in that. If you had to think about maybe the top 3 things that have evolved over your career to change how hepatobiliary surgery is done, what would they be?
I think the number one thing is that we work more as a team in surgery and medical oncology and radiation oncology and nursing and radiology and pathology than we ever did before. And so that has made huge inroads in pancreatic surgery and liver surgery, like they have in other areas as well. Pancreatic cancer is hard. Hepatocellular cancer is hard. And they're tough nuts to crack, but people are doing it. And we're doing it by working together better. right? So those case conferences, those things where every single week all the surgeons are there presenting the cases, and you have an approach where it's not just one maverick doing the operation, like we used to say back in the old days of Top Gun. It's not Top Gun surgery. It's a combined process of saying we're all together on this. So much so that if I do my operation, so the patient I did the operation on Friday, my colleague looked after him on the weekend because I had just been in call for a while, so I took a break on the weekend. My colleague looked after him on the weekend, and I know that she will look after him the same way I did because we all work as a team. So those team approaches, things have really made a difference in multiple areas within the care we provide for our patients. To extend that analogy a little bit further, nutrition, OT and PT, or occupational therapy and physiotherapy, and the preparation of patients. You and I talked about prehabilitation. So prehabilitation is something your listeners might hear about. It's where we try to optimize the patient before they come to surgery by making sure they get appropriate nutrition, by making sure they get appropriate amounts of exercise and some type of bulking up. We talk about bulking up because they're what we call the reserve capacity for an operation resides not just in your weight, it's in your muscle weight. And so the more you can have good functioning tissue that your body can use as a reserve capacity for the operation, the better you do during the operation and the better you get back on your feet afterwards. And that's important. So that first part of doing that, the first part of the three things you want, the first part is that collaboration. Mm-hmm. The second part is, I think, the science of medicine has gotten to be kind of at the cellular level. So as a surgeon, a lot of the things I do are structural. And I'm limited by what I can do structurally because we said the pancreas is a tiny organ, right? But at the structural level, at the cellular level, we have doctors who are figuring out the molecules that make a difference in these things. So the chemotherapy we have now is pretty much like designer chemotherapy. We have things that are very specific to a particular cancer and are very toxic to the cancer but not as toxic to the patient, right? So those things have made a big difference as well. And I would say the third thing is just getting back to surgery is that I think we do better quality surgery now than we did before. We understand some of these things that have matured so that we can provide safer surgery. And we know, again, to extend the analogy of the team, we know that that teamwork in the operating room makes a difference. Our anesthesiologists now work with us to say, if we're doing liver surgery, we keep the blood pressure in a certain area because it prevents bleeding so much. And then we can control that and allow the patient to go through the operation safely, but with less bleeding. Our nurses work together because we have complex pieces of equipment that we use for these operations. They can put them together for us as we need them to operate and operate them really well as we're doing our work. And that works really well. So those other kinds of things, we've looked at ways we do the surgery, how it works in Italy or in South America or in China or Japan or here, and we're sharing those little nuggets or we call pearls of wisdom about this works better than that, and that works better than the other thing, and we're all sharing those things a lot better and coming with better outcomes. And that's hard. It's a tough. It's always going to be tiger country. The structural aspect of this is not changing.
It's not going to change.
Yeah, people aren't going to
become
become.
tough anatomy.
Yeah, their anatomy isn't going to change. So it's always going to be tiger country, but within that tiger country environment, we're better at doing the things we need to do.
I guess one other thing, it's an extension of your comment on the first point of teams, because it used to be that you'd have individual surgeons in different communities, right, and sometimes in smaller hospitals, but with Cancer Care Ontario's initiative, I don't know, a dozen years ago perhaps, of consolidating so that there's larger groups. I'm impressed now that the hepatocellular group here and hepatobiliary surgical group here in Hamilton's grown to 6 surgeons. That's a formidable group. And then all the ancillary professional groups that are part of an overall team. Because there's good evidence that the creation of these teams leads to better outcomes and an improvement in overall mortality results. So it's good that the province did that some years ago, and I'm delighted to hear that Hamilton's got a formidable group of hepatobiliary surgeons that are available to the citizenry if they need this kind of surgery. It's been great learning from you, Dr. Dath. It's partly anatomy lesson, it's partly history of how things have evolved in this difficult area of surgery. And there's been a hopeful message too in terms of some of the newer strategies that are bringing better outcomes for cancer patients who have these types of cancers. So thank you very much. It's been a pleasure.
Thank you, Bill. Thanks for having me.
Thank you for listening to the Cancer Assist podcast. Find more episodes, resources, and information at cancerassist.ca or follow the Cancer Assistance Program on Facebook, Twitter, and Instagram. We'll see you next time.